Hello. Thank you very much for the invitation to present at this fantastic meeting. I'm Al Getgood. I'm a consultant orthopedic surgeon, knee surgeon at the Fowler Kennedy Sport Medicine Clinic in London, Ontario, Canada. I'm going to be speaking on my approach to multi-ligament knee injuries. These are my disclosures, none of which are relevant to this talk. I'm going to go through an assessment of multi-ligament knee injury, clinical examination, some imaging, treatment, and rehabilitation strategies. In terms of epidemiology, this makes up a small number of all orthopedic injuries with a male preponderance, and bilateral cases are rare. The mechanism of injury tends to be high energy in the majority, but certainly we need to look out for ultra low velocity multi-ligament injury in patients with higher BMI. This has been shown to be associated with really quite catastrophic neurovascular injuries. In terms of classification, SCANC has classified injuries based on the type or the number of ligaments and which ligaments are involved, but also a pattern of injury classification can also be utilized. In terms of the presentation, you need to understand the history and mechanism of injury and whether or not this is acute or a chronic presentation. Of course, if this is an acute presentation that's associated with high energy, then ATLS protocols are important, and making sure that we exclude life and limb threatening injuries. Following this, we should reduce the knee, do a secondary survey, and then document neurovascular status and perform a ligamentous exam. In terms of our vascular examination, we utilize selective arteriography and essentially an urgent cases where we have absent distal pulse, then of course urgent vascular consult is required. We do use ankle brachial pressure indices a lot, so if you have an ABI greater than 0.9, we can observe the patient for 24 hours. If it's less than 0.9, this warrants CT or angiogram. Neurological exam is very important. It's quite common to have common peroneal nerve injury, particularly associated with PCL posterolateral corner injuries, and in those with high energy. Of course, don't forget the ultra low velocity multi-ligament injury. These patients can be a very poor prognosis. It's really important that we document both deep and superficial branches at the time of our assessment. Clinical examination can be difficult. In the acute scenario, you may be just left with a very angry, swollen knee. In the chronic scenario, as in this case, then we need to do a complete examination. I like to look at knee hyperextension, and whether or not the leg drifts to the varus valgus. It gives us a nice idea as to whether or not there's posterolateral or posteromedial involvement. Looking for anteromedial rotation or external rotation, doing a dial test in a supine position, standard pivot shift test, and a reverse pivot shift test, looking for anterolateral and posterolateral laxity, respectively. And then looking at the knee in terms of varus valgus stress, both in full extension and 30 degrees of flexion, to determine what structures are damaged under these different loading scenarios. The dial test is very important. It's important to understand what you're looking for here. It doesn't always mean a posterolateral corner injury. On the left-hand side, this is a posterolateral corner injury with increased external rotation. But on the right-hand side, this is a young man with anteromedial rotatory laxity with increased external rotation. So the dial test is purely a test of external rotational laxity. We need to understand whether or not the tibia is subluxing anteromedially or posterolaterally. Once the clinical examination is done, then we look at our imaging. We correlate the imaging with the clinical examination. So plain radiographs is a start off with AP lateral and Rosenberg views. Stress radiographs are very helpful, and in the chronic scenario, hip to ankle alignment views are a must. The MRI will tell us a lot about our injury pattern, but remember, in the chronic scenario, it really is just a static image and doesn't give us any indication of laxity patterns, which is why stress radiographs can be quite helpful, and CTs can be used to assess associated fractures or whether or not there's arterial injury. MRI will pick up some subtle changes. So here you can see the bone bruise pattern of a anteromedial bone bruise in the femur, which is indicative of a posterolateral corner injury, and of course the alignment views that we've already talked about. Stress radiographs, so valgus stress radiographs, looking for side-to-side differences. Varus stress radiographs, again, these have all been clearly documented by the PRODS group, and PCL kneeling stress radiographs also helping to determine the grade of knee injury. Once we know what we're dealing with, then we got to make some decisions about ongoing treatment. So in terms of operative versus non-operative treatment, this is a systematic review that was done by the multi-ligament injury study group, suggesting that early operative treatment was best to improve patient-reported outcomes with higher rates of return to work in sport. But this really is based on multiple case series. Non-operative treatment I do utilize for isolated PCL injuries, particularly if they're lower grades. Try and get them into dynamic brace as quickly as possible. You can often reduce the grade of injury down by at least 1 grade, and also in patients who are asymptomatic. The absolute indications for early surgery, of course, are patients with vascular compromise, compartment syndromes, or the scenario here shown with an irreducible knee with a dimple sign on the medial side. This is an incarcerated medial collateral ligament, which needs early operative intervention. External fixators I try not to use, but will use them where I'm unable to hold a reduction, particularly in patients with obesity, and of course in patients with vascular injury. But we're trying to avoid the pins here, as shown on this particular picture, being anteriorly placed through the quad. Instead, we're trying to avoid the quadricep mechanism if at all possible. In terms of the timing of surgery, we try and let the soft tissue settle. So if the swelling is down, we try and get in early, less than 3 weeks. But if soft tissues are poor, then ice elevation, let the tissue settle, and then go back in maybe 3 months later. We sometimes will stage these injuries, and so in the example as seen before with that arcuate fracture, if I'm not able to do all the cruciates at the same time, I will do an early operative intervention, reduce the biceps and the FCL conjoint tendon with that fracture, repair the capsule, and then come back in at a later stage to do the cruciates. Repairing versus reconstruction, there are some studies looking at repair of the posterolateral corner, and we know that certainly in the example of the posterolateral corner is a higher failure rate. So my approach is to repair what structures I can repair, and then augment with reconstructions where appropriate, and this is to allow early range of motion. To do this, we need a range of graft options. My preference is to go with autografts where possible, and we have a whole range of different autografts, both of the ipsilateral as well as the contralateral knee. But of course, allografts can be also helpful as well if you have availability. In terms of some technical pearls, I like to write my preoperative plan on a board. This allows me to organize my thoughts, but also make sure everybody's on the same page in the operating room, and this helps maintain a momentum and keep a very efficient procedure. Examination under anesthetic is really important, so that we can ensure that we've got the right diagnosis that correlates with a clinical examination preoperatively, our imaging, and also our arthroscopic findings. We may need to change plan if we find anything else. I tend to do most of my extra-articular work first, and that's without a tourniquet. This allows me to do the dissection where the tissue planes aren't distorted, but also it allows any fluid to extravasate out of the joint when doing the arthroscopy, and it keeps it nice and safe for preventing compartment syndromes. In terms of looking at the individual reconstructions, so you need to think about the anatomy. So the PCL is a large attachment site with 2 bundles of fibers, the anterolateral posteromedial bundle, but it also has the meniscofemoral ligaments. The tibial attachment is 1 centimeter below the joint line. It's a smaller attachment than the femoral attachment. The meniscofemoral ligaments have an important role controlling posterior translation, approximately the same tensile strength as the posteromedial bundle, so we try and preserve these where possible. And because of the sheer size of the femoral attachment of the PCL, you get this differential recruitment of fibers throughout the flexion arc. And this is why there's an argument for doing double bundle reconstruction, with double bundle reconstructions as shown by the study by Robert Brad, being able to recreate the kinematics of the knee more appropriately with the addition of 2 bundles on the femoral side. So my preference is I do both single and double bundles, but when I'm dealing with a grade 2 intersubstance strain where we're trying to preserve the meniscofemoral ligaments, I will do a single bundle of transseptal approach, whereas when we have a grade 3 PCL, it's completely off the femoral side, no meniscofemoral ligaments, and I will do a double bundle reconstruction. And this anatomy has been beautifully detailed by Laprade and colleagues, and it helps us considerably when doing our reconstructions. And of course, we can use radiography as well. Similarly, the tibial anatomy has also been very nicely demonstrated by Leprade. In terms of our posterolateral corner reconstruction, well, the fibuloclavicular ligament is the main varus restraint of the knee, with the popliteus and the popliteofibular ligament as external rotation stabilizers. The fibuloclavicular ligament can be found by entering the biceps bursa as it attaches onto the fibular head with an average length of approximately 70 millimeters. The popliteus attachment on the femur is very easy to palpate as it sits within the anterior fifth of the popliteal sulcus. It has an average length of 60 millimeters, whereas the popliteofibular ligament, it originates in the musculotendinous junction and assists the popliteus tendon in providing static stability to external rotation and varus. Less easy to find, but certainly easier, can be incorporated into our reconstruction. We have these very nice diagrams that I utilize for teaching, courtesy of Leprade and Strauss, which really shows the spatial anatomy of the posterolateral corner. In terms of reconstructions, there are fibular-based and then there are more anatomic-based. I prefer an anatomic reconstruction, which incorporates the FCL, popliteofibular ligament, and the popliteus tendon. Leprade described this with two grafts. I prefer to use a single semitendinosus autograft using an adjustable loop on the tibia. This allows me to do a similar reconstruction just with one graft. And we've validated this through a cadaveric study that was done in our lab, and it's recently been accepted for publication in the American Journal of Sport Medicine. In terms of the medial anatomy, you can see here, this is the superficial MCL and the posterior oblique ligament. Again, this is the importance of understanding the anatomy and associated kinematic profiles if we're looking at reconstructing these structures. Because really in extension, the superficial MCL is taught, as is the posterior oblique ligament. But what we'll see in flexion here is the posterior oblique becomes loose. So it really has no control of either posteromedial or anteromedial rotation and flexion. Its primary role is in extension, controlling valgus laxity and extension as well as internal rotation. So my preference for MCL reconstruction is to do a modification of the Leprade technique, where I use two limbs of a semi-T graft rather than a single limb. And the beauty of this is that I can place a proximal anchor at the proximal insertion of the superficial MCL into one limb. Therefore, I've got graft from femur to proximal insertion and graft from femur to distal insertion using the two limbs. The posterior oblique, if the capsule is intact, I just do essentially an imbrication and augmentation with a synthetic. However, if we've got a deficient capsule, then I do a posterior, that's a sort of reconstruction of the central arm of the posterior medial capsule with a gracilis tendon autograft. And again, these diagrams can be very helpful to give us some guidance in terms of the anatomy in the OR. This reconstruction is very successful from a static laxity point of view. This was published recently, showing that valgus stress radiography following this reconstruction is effective. Another technical pearl is use of osteotomy. You've got to look at gait, and you've got to think about the issues associated with coronal plane and how that loads and causes more strain on our PCL and ACL reconstruction. This is a patient who had a failed posterolateral corner, who was in varus, and so he did a medial opening wedge HTO and didn't readdress the lateral side and didn't need to do any further reconstruction. This is a young guy who had a medial-sided injury associated with an ACL and PCL, and he was in valgus, and so we did a distal femoral osteotomy, followed by the soft tissue reconstructions. This is a chronic PCL posterolateral corner with a gentleman with a flat slope and hyperextension, and essentially we increased his tibial slope whilst also changing his coronal plane alignment, and that improved his tibial station quite significantly. In terms of our rehabilitation, the rehab goals are to protect graft in the early phase, to cyclic loading and gravity. We want to prevent stiffness, and we want to then focus on neuromuscular rehab. So this is a goal-based rehabilitation program with some early restrictions in place to protect our grafts. So using a tracker brace in the first 2 weeks, transitioning to a dynamic PCL brace, so that at 6 weeks we can start active hamstring If the PCL brace is in place, if no PCL brace, then we'll wait till 12 weeks before I'll start doing hamstring strengthening. And then from 3 months on, looking at neuromuscular training, again, using the dynamic brace with resolution of restoration of function and starting sport-specific drills at 6 months post and return to sport 12 months post. So this is an example of a patient of mine who's an 18-year-old elite-level cheerleader. Basically had a significant knee injury, so a varus injury with hyperextension. You can see here in a clinical examination, she's got posterior laxity, quads active test, and posterior lateral rotatory laxity, hyperextension. So her MRI confirmed an ACL, PCL injury. The posterolateral corner injury, you can see here bone bruise in her anteromedial femur. And essentially she had an early reconstruction with allograft, mixed allograft and autograft, and then rehabilitation following that protocol that I've already described. Here's just some intraoperative pictures, and then her post-operative films with excellent restoration of her tibial station. This is her approximately 9 months post-op with the brace in situ and back doing the sport that she loves. So in summary, we need to have a high suspicion of multi-ligament knee injury in the polytrauma patient. Of course, life and limb-threatening injuries take precedence. We need a thorough vascular and neurological examination. We try to avoid external fixators. Stress radiography can be very helpful. We look to perform anatomic repairs and reconstructions. We need to be aware of multiple techniques and graft options. This cannot be a one-size-fits-all. Alignment is incredibly important. We should address, don't ignore it. And then the question of early range of motion. We are involved in a large randomized clinical trial with the University of Pittsburgh focusing on timing of surgery as well as range of motion. This is called the STAR trial, and hopefully in time we'll be able to give some better evidence for our treatment decisions. Thank you very much for your attention and the invitation to be part of this great meeting.